We present to you a topic far and long overlooked in the world of plastic surgery, the cleavage and the breasts. Dr. Michael Miroshnik is our guest. He's an incredible plastic surgeon from Sydney, Australia, from Down Under. He has the most amazing, incredible results. Every time I show his pictures to another surgeon, they are astounded by his level of understanding and his artistic technique in recreating natural contour, shape, and form within the breast, as well as his ability to lift internally. I didn't know internal lifting was a thing. I didn't know so much went into designing the cleavage, but I certainly do appreciate it and really the artistic nature of it. I'm so happy to have Dr. Miroshnik here today, all the way from across the pond. It's such a pleasure to have you on the show.
For everybody who doesn't live in Australia or doesn't have a cell phone and social media, this is Dr. Michael Miroshnik that we're with. He's an incredible surgeon I've known about for, I think, about 2 years now, who is based in Sydney, and his amazing breasts are being seen around the world. And he's very, very well known for creating just amazing, very, I'd say, sexy outcomes, and his ability to share that with his patients is amazing. His patients send him photos all the time, over and more than I've seen with anybody.
I'm very thankful for that
really
too.
showing
Please
their
keep
amazing
sending.
results.
Yeah. Today I thought we'd talk about cleavage lines, and cleavage lines is one of those things that in the last decade has become the single most requested thing I have in my breast practice. And the reason for that is that it's just traditionally an area which is not thought of much, the traditional plastic surgery.
So patients actually seek you out for improved cleavage lines? Or,
Yeah, exactly. Because, I mean, the whole concept of breast augmentation, which is, getting into its 60th year now, was to make your breasts bigger. And then surgeons started talking about the importance of shape of the lower pole to make them last, but things like cleavage lines sort of got left out of the basket. And what I've done to kind of illustrate points is send you just some screenshots from my Instagram account just to try to illustrate, because it is a visual thing, so it'd be easy to just walk through some of these concepts. And there you go. So
if everybody realizes the breasts are next to my face, so I just rest my head.
We planned it that way. So these are straight off my Instagram feed, and I'll just sort of highlight some of the photos that my patients sent to me, and what I aim for with cleavage lines. So firstly, we're talking about cleavage lines, so we're talking about those two central vertical lines that curve out into the fold. And with photos like this, you realize, they're very curvy, hazy, and can be very attractive. And what makes them attractive? So what I aim for as a goal is firstly to have the cleavage lines close, so about a finger breadth apart with all aesthetic breast surgery. A finger breadth apart is about right. And when you look at the lines, just like other anatomical lines on the face, and Ben, you'd have the same rules for nasolabial folds and things like that. You can see their special line in that they start very, very hazily, and there's an actual gradient. The gradient starts to get heavier and heavier and heavier, and as that vertical line becomes a horizontal line and the inframammary fold, that shadowing, if you like, gets heavier, and it shows us that there's more volume on the bottom than the top. And so it's when you look at these photos, they all have that gradient, and then the heaviest part of the gradient is always down the bottom where the fold is. So when we're trying to create that, for example, if we're trying to create that with fat grafting, we know we want to put a very small amount of volume of fat on the top, and then start to get more and more and more and more and more and more and more to create that gradient. The other thing that's important in creating that gradient is to create that really heavy lower pole fold, or the inframammary fold. And yes, we can do that by increasing the projection of the implant, but we can also do it by increasing the force upwards. So the stronger our repair of that fold is, the more shadowing we're going to get, and the stronger the cleavage line we're going to get. So if you think of it as a summary, the cleavage lines are symmetrical, they've got a gradient, they start vertical, they end horizontal in the fold, and they have a curve in between, and that gradient keeps adding and adding. And that's what makes this line quite special. It's not a straight line. It's not the same amount of shadowing. It's a gradient amount of shadowing and curvy. Now, these photos, all from my Instagram, they really show why this has become so important. And the reason is we're kind of a slave, us plastic surgeons, and in any part of plastic surgery, we're all slaves to fashion, right? So in the last 10 years, particularly in Australia, where we live in a warm environment, there's all these dresses now that just didn't exist before. So strapless, backless, plunging necklines, dresses like this that are designed specifically to A, show the cleavage lines, but B, how can you wear a bra with these, right? So all the support to make these cleavage lines now has to be internal, because we want that result to happen with no bra, because these dresses don't support bras. And so, as a side point, I think that's why there's a real miscommunication between, if there are any surgeons listening, to what we read in our publications and the Instagram time surgeons like us that communicate and see results from our patients, in that this is what patients want because this is what they wear. But if you read PRS, there's no mention of anything like this, because there's no communication between where fashion is going and what surgeons are doing technically to create that. And Instagram kind of bridges the gap of that.
So what I've noticed in terms of my own fashion sense, being a facial plastic surgeon, is I deal with a lot of women. So I'm very good now with understanding jewelry, and I'm very good with bags, with purses. I see a lot of purses, and now I'm into purse fashion. Like, it's something that I never would have thought of in the past. For you, you have to be now very aware of kind of sexy nightgown, dress, and bikini fashion, everything.
Well, right. So when someone comes into a consultation, rather than obviously, the standard things like what type of look you want, what, natural versus proportion, out of proportion. The other thing is I say, what type of things do you want to wear? Like, for instance, some people do this right before a wedding. Or some sort of red carpet event. Now, red carpet is a great one. If you look at the Emmys, this year's Emmys, I just did a talk just before the Emmys. Every single main star in the Emmys wore a strapless dress or a plunging neckline. Now, if their cleavage lines were not right and they did see an aesthetic surgeon, that would be a disaster. So we're integral in the process of making that dress work. It sounds funny, but like at the end of the day, we have to make what we do work with what our patients are buying in terms of fashion and clothes. Yeah, and so cleavage lines are a big part of that.
Yeah, and I see specifically what you're talking about. I didn't realize it till now. I've met a lot of women who complain about that exact thing, where they say their breast look great when they're wearing a shirt or when they're wearing a bra, but when they take it off, they said it doesn't look good anymore. They look asymmetric. One goes out more than the other. They sit too high, they sit too low. There's all these different things. So you're kind of looking at now the much more forward as far as the end result goes with gravity, where it's going to be sitting truly. And you have to make the finest little refinements to do that. And also looking not just at the inframammary folds and the lateral show, but the medial portion of the cleavage as it's coming down and curving around.
Yeah.
And so what do you do to... how do you predict that?
Yes, exactly. Well, this is the challenge of our craft. So if you just move on. So yeah, this is just, again, a different patient, exactly the same dress, and this is straight on her Instagram profile. So yes, obviously some people's anatomy is very conducive to forming very stable, close cleavage lines with implant surgery and fat grafting, and others are more of a challenge. So let's move on to the next one. This is just to show that even bikinis that are out there now, they don't really have much support. So the cleavage lines have to be there. We're not wearing sort of clothes, particularly here in warmer climates, which are, we're warm, which have a lot of padding or support to push the breast together. It's all got to be internal. Let's go to the next one.
And these are with really soft bras as well. These are not like wired.
Right. So that's right. So this is a type of case that, makes any breast aesthetic surgeon go, well, this is challenging, because there's a couple of things going on in this before. So have a look at the original breast. So you can see that nature has made these breasts what we call constricted. So their base is very narrow, or tuberous, if you like. But on top of that, on top of making the natural breast so narrow, so it gets nowhere near the cleavage at all. It ends sort of here. We want it to end here. On top of that, nature's given her a sloped chest. So the chest, the ribs are actually sloped, and the breast sitting on its slope. So if we put an implant there, what's it going to do? It's going to be a kilometre apart, or I should say a mile apart. We're not in the metric system anymore. We'll make allowances. So there's going to be a mile apart here, isn't there? So if we just put 2 standard implants in there, standard breast job, just like you would see in the textbook that many people do, there'll be 2 implants this far apart because they're on heels, and so they want to fall to the side. And guess what? When she lies down, they're going to fall even further because the gravity would now be against you as well. So we need to do internal maneuvers, basically, to stop that from happening and to allow her to wear one of these bikinis, which is what she wants.
Right. And how are you, because I've seen it a lot where you're upsizing a pretty tremendous amount for a patient. How do you do it where it still maintains these soft contours where it doesn't look like they're pushing together, or it doesn't look like there's some kind of encapsulation happening or bump happening in the middle and it's just tearing under the skin is what it looks like to me on some people.
Yeah, good point. So that's a question of coverage. So we've got a foreign object there, and we want to make it look like there's no foreign object in there. So we're going to put as much material as we can on top, muscle, fat, existing breast tissue, and so forth, to make sure that there's coverage and we can't see what's underneath. And that's really fundamental. But for any of the surgeons watching here, and we won't make this technical at all, but to do things like this, there's 3 main things that are done extra. So the incisions are exactly the same as every other breast augmentation incision, but what's done internally is much more. So first of all, the first component is to do what I call a custom dual plane placement, where we preferentially not just move the muscle up, but actually tilt it, so cant it, so expose a lot more breast medially, because what's going to happen then is it's going to preferentially expand or create skin. We're going to create volume more inside than anywhere else. So if you have a look at this, if you had to point to one area, where has most of the volume gone? The implants are all made in a factory, but we've made most of the volume go in the middle, haven't we?
Right. Mm-hmm.
And so we've done that by telling the muscle to push volume there. So that's one. Secondly, we need to put a very, very strong internal bra repair. So I use the word internal bra a lot, and internal bra just means that we're putting a little bit like, just think of an underwire bra. How do underwire bras work? Well, they've got that big wire underneath, right? So we're going to have to put a wire equivalent inside to do the same job. And you might think, why underneath? That has nothing to do with the top. But if we have volume loss underneath, then we have less volume that can go there. We have to put a wall to stop any volume dripping down, okay?
Yeah.
And that's what happens with bottoming out.
Rather
than just, go on.
Well, so there's a huge, the difficulty I see in this, and again, I'm a facial surgeon, but I've seen a lot of breast work in the office and kind of in my life, I'd say, but just seeing this, the nipple positioning, even the vector is appropriate. And I've seen that really go awry with a lot of larger breast implants. And these are, again, they're not small increases. These are pretty substantial increases that remain natural and balanced, where you have the proper cupping underneath and the nipple is still sitting where it's supposed to be, as opposed to pointing down and out or inwards. So how are you controlling that? Or do you take that into account with the design, with the fat and everything else that you're doing?
Yeah, so once we talked about, medializing the muscle, we talked about strong support, and then that important component, which you just pointed out in perfect timing actually, is to put fat on top. So anywhere where we don't have enough natural breast tissue or fat, because remember, real breasts are made from breast tissue and fat. We're trying to emulate that. We're going to have to add fat, and 80% of my work has some component of fat grafting. It's very hard to camouflage such big things, just as you rightly say, unless we put some padding. And so anywhere where we're going into thin skin in the sternum and we've created volume or expanded skin, we have to then add fat. And that fat can come from many places. And if it's done very superficially in that subcutaneous layer, the survival rate's very high.
Yeah. And these pictures that you get, these are like the most seductive, sexy pictures.
Yeah, I know. These are my patients. Welcome to my patient cohort.
Yeah, they're gorgeous Australians, I'm sure. When I get photos, it's always like of their face this close up and trying to show me the smallest shadow that doesn't exist in like real life, and that's what I get all day. Yours, you're getting these super sexy, kind of laid back, and it's very nice, like shirts and lingerie and things like that. I had a very super jealous ex-girlfriend, and if I had a text message from somebody else, even saying hello, like I'm your cousin and I miss you, she would like lose her mind.
Yeah.
With this stuff, I can't imagine all day what you're getting, but you must have a very well serious appreciation for it and for kind of the beauty of it, because this is a real life practical photo, and I think that's awesome that you're seeing these things, because you
Mm.
see really what they're seeing every day, and none of these patients are sending it to you with a big solid bra on.
No, that's right. As I say, there's because again, this talking about cleavage, and because this is a great example again where cleavage is the number one hardest part in this case. You can see that now, because look, now that we're focusing on cleavage, you can see she's got breast tissue. It's all on the side and the bottom. We've got nothing in the middle. There's a very, very big gap to fill, and so naturally the first photos she's going to send us and show are going to be unsupported cleavage lines, because that's what she could never do, and perhaps a dress like this she couldn't wear before or wasn't confident buying, and now she can. And I'm fortunate in that most of these girls actually have their own Instagram account, and so they kind of document their journey, and or the initial swelling and this and the bruising from the fat grafting and so forth, and then it ends in these sort of transformations when all the healing's done. And so I get to my team here cherry picks these photos,
Mm-hmm.
and then particularly ones that show particular techniques, and I'm very fortunate in that I could just repost it. It's just like my Instagram's account, like shouting out to all these people, really. Yeah.
Yeah, and it's amazing. No, it's amazing, and they're all kind of involved, and I'm sure they have a community where they talk to each other as well, which is really
Yeah, we
a
do on
powerful
Facebook.
part of this whole social media. And for a lack of a technical understanding of what's happening in your world, I see a lot of girls on your page who just play with their boobs. What are they doing there?
So there's one of the difficult things that surgeons don't have much control over is when you have someone with very little and then you're adding so much, like you say, to make them feel soft, and that's a time thing, because we have to wait for the skin to expand, and then the fat to take and so forth, and all the healing to happen. And so it started off with one girl kind of showing, oh, look how soft they got at the end, when in the beginning they're so firm, and that sort of just caught on. And then people saying, oh, how soft do they get? And so that's how that sort of came about, to
So they're
show
doing
that they can be
exercises.
squishy. Yeah, no, that's not part of the regime. You'll note, years ago, when what's called a mega pocket was sort of the way to do breast augmentation, our surgeons used to say you need to rub your breasts, or just sort of massage them
Hmm.
to get the best results and avoid capsular contracture. That's very old school, and that is not part of the regime at all.
Okay, so it's more demonstration
That's
of
just
success.
something, just a demonstration of softness from the patient. So that
Gotcha.
was not surgeon advised. Yeah.
Sure. So,
Look, it's just more examples of. I'm just seeing what's up there, but more examples of very bony chests and how much coverage we got and how much recruitment of cleavage line we have there. But this girl wanted more of a maximized sort of look, and so how close we could get
yeah,
with standard
and
implant surgery, fat grafting. Yep.
yeah, and again, for a substantial volume increase, they still say stay so soft looking. And for
Yeah,
patients who don't understand, when you do, like I've seen just superficially placed breast implants where it just looks like a bag of saline, like a balloon was
yeah.
placed into the skin. This looks like it's soft and well supported.
Yeah. So again, the coverage thing, this is a great example of coverage and how far you can go with coverage. Now, sometimes, you might need more than one fat session to do that. And stage surgery, if you want a certain look, I just sort of say, I know what you want, I get it, but you're going to need two surgeries. It's not maybe, it's not if, it's just some things in breast need two surgeries. And when it comes to complex revisions, I just sort of, two surgeries is almost the norm. So it's better not to compromise the result. I just find it really hard to compromise the result if I know I can get exactly what they want with two surgeries. And sometimes to get that, you need it. And that's something that a lot of patients have to understand. But once they make that decision, they're actually very happy for it. But here's a good one with coverage. I mean, when you have coverage, things appear softer, hazier, and coverage comes from muscle and fat, and sometimes meshes and things. But basically anything we can lay on it to cover the fact that there's an object there.
So this one is a staged procedure. You went back and touched it up?
This one, I don't think this one actually was, no. But if they need a lot of fat, sometimes you may need more than one session of fat grafting.
Yeah, and I think that's much smarter. It's the same with the face as well. If somebody needs fat, I don't like to do it in one session. I like to put a little tiny amount. I know that my level of control is limited, and the more I put, the more chance of irregularities I have. And then I go back and I touch up with a tiny bit more, and sometimes even a third session. But doing that, I've taken my revision rate to almost zero with fat. Like it is zero. I've never have to fix anything with fat because of that.
Yeah, same. I'll communicate again with surgeons that I think the one thing that, particularly once you start to specialize and get into the minutiae of craft, if you know you need two surgeries to get an optimal result, just do it. And I've done that now for many years. And again, you get down to a very, basically a non-revision rate because you've staged your operation.
So did you ever see the Friends episode where Rachel is dating a gynecologist and she wants to go home, and then he's comparing. He says, "Rachel, you know how you work at a coffee shop, and sometimes at the end of the day, you just ask yourself, like, oh my God, if I see one more cup of coffee today, I'm going to kill myself." And he thinks the same thing about gynecology. You get a lot of photos like this. I don't think it's anything that you translate to your personal life.
I mean, look, no, not really, because you just see, with this photo that you have up there, I just sort of see, I see the technical parts of it, and if it's a technical success and everything's worked the way it has, you just get that kind of, work high kind of thing.
Yeah, but these are amazing photos you're getting because you do see so much shadowing happening. So. You're explaining the gradient of the shadowing as you come down from the medial cleavage plane going down under the cup, the cupping portion. And it is so smooth and so incredibly symmetric. Now, nothing's perfectly symmetric. They're going to have different shadows on each side. Yes. But the photos they're sending you or that you guys are picking are very, very indicative of the changes you've made.
Yeah, absolutely. Look, these are, these ideals, and some people have ribs out of place and so forth, or they just don't have the fat, and they won't have the same level. But these are our ideals, and that's what we go for. And knowing the fact that you're after a shadow is really you're almost half the way there, because then as a surgeon, for example, when you're creating your pocket, you're leaving more wispy fibers attached on the top and less down the bottom, so you get more of a gradient. And if you're fat injecting, you're putting less on the top and then more on the bottom. And if you're reinforcing, you're putting a lot more strength on the bottom and there's none on top, and so forth. You're actively doing things to create that gradient. Will already make you achieve a sort of a more harmonious cleavage line.
And is designing this medially the same as it is laterally, thinking if somebody is going to be laying on their side, how it's going to look in terms of the gravity or how it falls?
So we were talking about medial cleavage lines, if you like. Now, lateral cleavage lines are side boob. So if you think of someone, we saw someone with a pigeon chest like that, but some people have a funnel chest. So their breast bone, if you like, their sternum and their ribs are going inwards like that. So over here, I do a lateral dual plane. So now, if this is my muscle, when we go up, we're exposing more out that way to create more volume push in that direction and stop the implant sinking in. So there we're focusing on lateral cleavage creation or side boob creation, if you like. So basically, you alter the the technical aspects of the operation inside based on patient anatomy and, of course, their goals. But the patient anatomy is everything, really.
Yeah. I mean, these are amazing results, and these are more tuberous looking.
Yeah, so I just sort of threw in a tuberous breast because it was such a good photo. But again, have a look at if you had to say, where have we added most volume? Has it been added in a proportional manner? If we divide the breast into quadrants, and that's what I often like to do when we, when you assess a breast, where does it need? If say you have a clump of volume like that, where is it going to benefit most? On the top, on the lateral area, that side boob area, the cleavage area, or the bottom. It's clearly in tuberous breast needed in the middle, right?
Right. Yeah, definitely medialized.
So we need to,
there.
whatever we're putting in there, whether it's implants, fat, or everything, if we're throwing everything in there, we want to favor everything to go medially more. So for simple things like, we are not traditional teaching, again, we're not going to alter the vertical position of the breast fold as much as we can. We can make the cut lower to recruit skin, but the vertical end, in other words, when we're choosing an implant, that bottom of the implant, we don't want to lose any volume there. We want it to all to go that way. We're going to actually shut it off and so forth. So we do technical things once we have a plan to put volume asymmetrically around the breast, not all the same place, because that's the traditional teaching of augmentation. Just put it all in the same place, a little bit everywhere, keep the nipple in the middle. But that would be a disaster again, because there'll be so much separation, and you can't wear any of those dresses or bikinis.
And are you predictively kind of planning this in terms of where you're going to do your injections beforehand from your experience, or is it during the procedure it's easy to kind of see everything? How does it work?
So pretty much anyone where cleavage is a priority and there's not going to be a problem either of coverage or having the cleavage lines apart, will have fat grafting. As I say, my fat grafting rate now is approaching 80% of patients. With mastopexies and lifts, and we'll go to that in a second, they're mostly fat grafted as well, because the skin over here, when you need a mastopexy, when you need a breast lift, the mastopexy is usually quite deficient of subcutaneous fat. So we're going to have an issue there as well. So I always have that ready to roll, because it's, once you do it a lot, it's quick, it's easy, it's an excellent adjunct, and it's predictable once you sort of, your team gets the hang of it. So I find it really useful, as you would in facial surgery.
Mm-hmm. And so here you're looking at kind of more of a flattened, lengthened, asymmetric breast with very medialized cleavage way up top.
Right. So when the cleavage lines get too long, again, we're not talking about the other aspects of when someone needs a lift. There's nipple aspects and how much skin, they have that's touching the abdomen and so forth. But once the cleavage lines start to get too long, you can see, I chose this perfectly because it shows that these dresses, again, if we go back to the fashion aspect of it, just don't really work, because, I mean, if your cleavage line is a mile, notice that, long, the window where you're trying to show those cleavage lines is not going to look right. It's too much vertical. So she needs a lift, because that curve has to come out a lot quicker. So when I plan any lift operation, I map out kind of where I want those cleavage lines to sit. And because at the end of the day, even though the breast is going to be there, we're going to need that window where those two cleavage lines are nice and close together. And you can see these are too long, and they need to tail off.
Yeah,
now, in this case, this is
there.
Right. So this is a lift and implants in one surgery, but if I think I can't do that, I very easily say, no, we have to do this in two surgeries, because for whatever the mechanics of it, I don't think your cleavage lines will get close enough or showy enough to do it in one go. And that lends itself to its two-stage. And there's a lot of girls there that are called Doctor in two-stage, Doctor in two-stage lift and stuff. And they needed two surgeries to achieve this sort of look and be able to go braless in a strapless dress. So approach a augmentation result, a primary augmentation result.
Yeah, another important thing that you see with shadowing is that it's a smooth transition from her pectoralis, her pec, is coming down from the arm to the breast. You don't see a step off between muscle and implant or volume there.
Right, exactly. So that's an area, a very good point, where, people, when they divide pec, often do it in a step-like way. But again, the way is to try to kind of chamfer it in a wedge-like, just take fibers off bit by bit, so you can't actually see where pec ends and breast starts, and then put a lot of fat in that area. And then you tend to disguise that transition point. Yep.
Yeah, and this is an amazing amount of support. I keep looking, because right now in the photo below, she's not wearing any dress, no support. She's coming out of a pool and leaning forward, and it has an incredible amount of support compared to her natural amount.
Right, so that's the lift, and then you've got the internal bra inside, which is either a long barbed stitch, which is a very, very heavy support layer, or mesh. So it's much more than a standard breast augmentation or lift where many people don't put any support.
Mm-hmm. So is that a permanent stitch that's sitting inside?
Sometimes permanent and sometimes long-lasting dissolving. The modern barbed stitches that we have are really excellent, and I use them again just so often. They're just always there, ready to go. And it's a surgeon call where you're going to use, generally the permanent ones they use for revisional work, and the dissolving ones for first-timers. Yeah.
Yeah, and so this is
this is a
similar.
lift and implants again, just in a standard before-after view. But the main thing I just wanted to show in cases like this, that again, when we talk about in conferences and things about lifts and implants, success is sort of measured as the implant. The breast used to be here and now it's here. And again, there's just no mention of this gap or what those cleavage lines are. In lift and implant surgery, there's so much emphasis on just doing this successfully. There's very little talk of this. And what happens is if you do that, and then you see this in, surgeons saying, that it's a success, everything's good, but then the patient actually wanted to wear a bikini or one of those dresses, and then they're not seeing the lifty bit, they're just seeing this. That's all they're seeing in the result. And they say, I still can't wear that dress because now I had long lines, but now they're far away lines. And so in someone like this, where I know there's too much skin medially, and we need to create a skin deficient environment to create tight cleavage like that, there's so much skin removal that we need to do to create a skin, and plus I know I'm going to need 2 sessions of fat grafting, one during the lift stage and another one before the implant goes in, plus I'll need to double reinforce the fold. She needs 2 operations to get that result, but she'll have close cleavage lines.
Yeah, and another thing that I noticed, which is a real important part of youth and sensuality, is the glow that you have to the skin. And I see the same exact thing when I'm doing facelifts and neck lifts. The neck, the neckline, the collarbone, and here on the upper chest, it starts to glow. And that glow is a very sexual young thing. And you see it on all these patients, every single one of them. You're seeing that they're actually glowing now on the chest from having more proper contour everywhere. I'm assuming, they're not sprayed with massive amounts of oil. It looks like they all actually glow.
I mean, that's another whole topic, which is, so, we mentioned fat grafting and passing, but I really think the reason that cleavage lines get fractitis so much in my practice, my fat grafting is literally just under the dermis, just literally under the skin. And that crepiness, obviously, as we lose that subcutaneous layer of fat everywhere, you get more crepiness. And in areas that are on show, we need to support that with more fat, particularly after breastfeeding, or to lose that crepiness. So the fat grafting is extremely superficial. And in cases, revisional cases, it's even almost intradermal. It's extremely superficial, and that's what contributes to that glow, as you say.
Yeah. So I see this very often. I'm staring at the face, and you see this loss of like radiance and glow over time, and I attribute it to loss of hyaluronic acid content in the face, which you're losing kind of the supple, cushiony layers of the face where the hydration is, and a little bit of loss of fat. And when you replace them, it looks amazing like this. They start to become bright and radiant again. And it's really difficult to achieve that so uniformly like you do, just all the way around. It's just everything is bright and matching, and you don't see any step-offs or irregularities as you're going. So I know how difficult it is from all the fat grafting that I do as well. And here, this is a lift again?
A lift again, and this is, look, I was going to say, some people say, well, we know what's wrong with it before, but again, it's just listening to the patients. There's nothing wrong with it before, but in these types of women, she specifically wants that kind of braless look where the cleavage lines are higher, closer, will support a strapless dress, and they don't have to wear a bra. And so unless you understand these things that I've been talking about, you're kind of, you're not sure what it is you're actually doing, and so forth. This is a lift, implants, and fat graft, and internal support, again, principally to be able to have that kind of youthful look. The gain as well, remember, the higher the breast is, the more torso we have exposed. So you've got breasts here, and then the rest of it's your waist and torso. If your breasts are here, not just on skin contact, but your inframammary folds actually descended with time, and everything gets lifted up, we expose more torso, which again looks more youthful and less frumpy.
Her waistline looks better.
Definitely. You see more of it. Yeah,
it's impressive. And you even have one of the biggest breast connoisseurs in the world is my friend Alec Monopoly, um, and he's complimenting your work as well.
Thank you.
He's a big connoisseur.
We should have him here on the Zoom live for tips and things.
Yeah, well, that's all we talk about when we FaceTime. But
this is good. So this is no implants. No implants. This is lift and fat distribution redistribution only.
This is a life changing.
So when you bend forward, obviously when you bend forward, all that skin that was sitting on the torso now falls forward, and again shows the separation. You also, again, you mentioned the thinning of the skin with loss of subcutaneous fat. Yeah, and so this is only from redistributing usable breast tissue, plus or minus the addition of exogenous fat, again, we can improve, use your own, clay, if you like, if you've got it and it's usable and it's not too strung out and unusable, to shape it to some of these ideals. But of course, there's things that only implants can do, like go above where the breast used to start and also create that very strong gradient down the bottom. But yes, you can apply a lot of these principles in mastopexy work only.
I can't imagine getting that improvement without an implant. And it looks like the breast tissue when she's leaning over is just hanging off the chest wall. Like you don't have any continuity of the muscle to the breast tissue.
Yeah.
So these are really impressive, and this actually does show the torso changes.
The torso,
yeah.
Yeah, so look,
she looks
just
taller.
Quickly, she does, yeah. Just quickly to the surgeons who are listening, and we will have a technical one of these, so we can talk about the technical things, and you can sort of, say what people do. But basically, every single lift patient, every single reduction, every single mastopexy, I reset the inframammary fold higher. Now, does that last? Does that happen? I've been doing this for many years now, and I can tell you their torso is long. I mean, basically, it's similar to resets anywhere. If you've got an anatomical structure, we suture it higher. Because the idea is we're trying to restore that torso length of youth. And if you're doing a breast lift, that will add not just to the shadowing, and again, you can see how that crisp that shadowing is underneath. That's from the internal bra, but also the height. And I don't have a long-term trial, but I've certainly been doing it for many years, and to the point that every single reduction and mastopexy will have some sort of internal bra in my hands, because it creates this sort of effect, and is very easy and worthwhile to do.
So
again, that's no implants. Yeah, it's just a mastopexy, just a lift.
Yeah. So I think a general understanding a misunderstanding of breast surgery is that anybody can do it. It's the easiest surgery to do. People do plenty of them in a day, and you have very busy surgeons, and they just go pop in these implants. I mean, this looks to me much more artistic and much more difficult to take in all these factors. And I don't think the basic breast surgeon can get these results consistently. No way.
Well, I mean, that's one of the advantages of specializing, just, choosing one area you love and doing it. And this is my area, so every case is, I think of it in these ways. I think of the torso, I think of the cleavage lines, I think of the side boob, I think of the anatomy and so forth, where I can get fat. It's just part of every single assessment, because this is, I mean, they're all connected to one another, aren't they? The breast is connected to the waist. You're going to judge the breast based on the waist. This is just a quick one. So this lady had implants, done elsewhere, and obviously one of them sorted out. And again, guess what? Everything you can see there, one of her main complaints is that she has that classic faraway cleavage lines, looks fake. Doesn't want implants anymore. So this is removing the implants and reshaping her natural tissue and adding some fat. And you can see we've actually got closer, more hazy and gradient-like cleavage lines than with implants. We've got it with real tissue as well. So just the principle and thinking about what constitutes a lifted and very aesthetic cleavage line with that gradient like we talked about and the shadowing, you can do it with real tissue better than with implants if the implants are just placed in a haphazard manner or if a lift is done inappropriately. So it doesn't necessarily mean implants. It's these principles
Yeah.
that are really a kind of call of our generation with breast surgery, just have to be thought of. That's all.
And when you see these kind of bony irregularities and asymmetries, it makes somebody look unhealthy. And then you see them
Yeah.
afterwards and they really look healthier. And here's another
Yeah, there's another
example of that.
example.
Yeah, it doesn't look
Yeah.
healthy. It looks
No, that's
contorted,
right.
distorted. Well,
That's right.
is this
And
somebody with a prior implant?
yeah, so this person had previous implant surgery, has implants above the muscle, and I think she had a previous lift as well. And now she's had a redo lift, fat graft, implants dual planed with internal bra and fat grafting, usual complaint. But again, the reason I put this one in is, again, look at the photos she's put to, I mean, remember, these are things that they sent to me. So why choose this? Because this is how she saw herself. So yes, there's all these elements of the breast, but what is she most concerned about? Her cleavage lines, because when she goes to a birthday party or wherever it is, people are going to judge that area. They don't see the rest of the breast. They actually judge that the most. And again, that overriding point where us surgeons have to realize that those cleavage lines are, if not the most important, they're way up there in the
Yeah.
importance of any result in aesthetic breast surgery
And
because of fashion.
yeah,
Yeah.
and the photos you pick are so perfect because, again, the complaint that I see from girls that I know, from patients that I have, is that they look good in a bra. As soon as they take it off, it doesn't look good
Right.
anymore. This is somebody wearing a robe, and
Right.
it's so good that it's caught my brother's attention. He's watching now
Great.
too.
Excellent.
See,
If I can impress your family, then my job for today is done.
so so these breasts look like somebody placed them kind of in her mid abdomen.
Yeah, this is a hard case. So these are actually just very old implants, and this is sort of, you know, the classic older style operation above the muscle. They've both got capsular contracture, which is severe, so they'd be painful, uncomfortable, and guess what? Very wide cleavage lines. Where's the gradient? No gradient, and all these things that we don't have, and they're too low and too long. And these you know, these are difficult, but again, it's the same principles. We think, where do we want those cleavage lines? They're going to be much higher. We want the gradient, we want much shorter, and then we execute it with all the principles we've talked about. And from an assessment, I can't get a result that I'm happy with in one surgery. So this is in two surgeries, where the first one was with no implants. We got as much fat graft and tissue redistribution as I could, let the skin settle, let the skin get better its inner glow, as you say, because the implant's out, the skin thinning's gone, any extra fat is taken, and then have a second session of fat grafting, and then the medial dual plane and internal bra. And then you've got a lifted result with close cleavage lines, and you can go braless.
Yeah, and I mean, if you look at her upper chest over here, now it looks like mine, which is glowing and beautiful and healthy. But it really is like up here is just like brightened up, and you've completely changed her proportions.
We need to do this with a face filter. Is there like a filter that we can do it in, like with unicorns or something like that? And then we're both going to look very glowy.
You actually can. You can do like I've got like that thing on my head now. You can.
And you told me about this now?
Yeah, see, so I got a filter on it now. There you go.
All right, next session.
We'll do that next time with filters only. So this one I think is just like super impressive as to how it changed the height of the torso and the upper chest.
Yeah,
completely.
exactly. You're noticing the torso, aren't you? So, you know, the torso height's a big component of the overall result. So even if you didn't say anything about the torso, you would compute it when you see it, because you see the long torso and you'd say, hey, that's a more youthful result.
And so these are some breasts that most people wouldn't complain about, but now that we've become cleavage specialists,
you see the
diastasis or the spread of them.
So I just want to quickly talk about this one, because it really shows why we see a lot of breasts like that photo. If people aren't familiar with my Instagram, I always have the before on the top left, and then the others are the after. Just the way it's been going for years. So if you look at the top left, it's a standard kind of breast augmentation, standard teaching. Nothing wrong was done, because when you think of breast augmentation and when you're taught breast augmentation, you're a surgeon and so forth all around the world, it's all about trying to create volume down the bottom. We say, well, you know, she's only got nothing, so we need, most breasts, you know, they have 60% of their volume below the nipple. We need to lower the breast fold and then create volume down the bottom. And then, hey, presto, you've got a big result. There's no mention about cleavage lines. In a case like this, when you see that type of sternum, so when you see a very wide sternum, massive separation, and a very wide attachment of pec major, that is the hardest part of the operation, period. And everything has to be focused on getting that. That is now the top priority. We're not going to inferiorly expand. We're going to medially expand. And that's, you know, when we talk about the technical aspect of it, this is a case where we don't want any volume loss in the vertical position. So we've raised that fold back to where it should be and put all the volume in the inside. Whereas originally, and all breast augmentation planning is usually based on inferior expansion, we're doing medial expansion. We're putting volume that way, not that way.
So
and
you have
that's
to
why you
convince
can't
it
just
to
do
go.
You can't just do that kind of formulaic way when you have a chest like that, because you know the cleavage lines will not be, you know, conducive to wearing all those clothes.
Yeah, and I think the stakes are higher with this kind of breast that already looks so good that you have to be very precise in terms of what you're doing, because you're trying to get this implant or the volume to go towards the path of least resistance with either gravity or positioning. So you're forcing it to go that way. And this is somebody actually who's interesting because topless, both photos look nice. I think the second one obviously looks better, but with a shirt on or with a dress on, she looks a little skeletonized and bony, and somebody who you could walk up to and put your hand on, kind of on their heart, versus the second one. Now you can't do that because it's a woman and there's breasts there.
Yeah. I mean, again, as I say, there's nothing wrong with you know, the first, because it's done by that standard model of surgery. It's a 6-month result. It's not bottoming out. It's just how it was done, because, you know, the surgeon's chosen to recruit more volume down the bottom. But really, you know, and again, it's a personal opinion, but I would, in this type of case, prefer to recruit most of it down there and not lose any volume down the bottom. Put the volume there. As I say, choose that for where does that volume belong most, and that's where I would say here rather than here.
Yeah, and then these breasts, there's a little bit of asymmetry going on. The nipples are in different positions, and the
So this has had no lift. This is just to show you again with when you lower that breast fold, you are stealing torso and you are always stealing cleavage line, okay? Because the volume is, so as we're lowering that fold, sure, we create shadows down here, and that's cool, you know, that's the natural sort of breast augmentation, but we've stolen volume here, and we have stolen torso. So the torso is getting shorter and shorter. You're kind of robbing, you know, the classic plastic surgery thing we're all taught in med school, you know, robbing Peter. Do you have that expression, robbing Peter to pay Paul?
Yeah, of course.
Might be an Aussie one. But yeah, so the consequences of creating a big, curvy, sort of pendulous sort of look down the bottom is less torso. Less torso always looks a bit older and frumpier. And so, and less cleavage. And so this is no lift. It's the same incision. It's underneath. It's just much more internal support underneath and much more directional push of implant towards the cleavage.
So this is without any lollipop or anchor?
No lollipop, no lollipop. So all that skin that's been recruited used to be abdomen. It used to be waist. Yep. And it's become breast. So it can be just pushed back down and made abdomen again. So it's these types of cases, if you do it as a lift and you've taken the skin out, it's also not great because we haven't put that waist back. We want to put that abdomen back. And so we can sew that abdomen back. Exactly. Yeah. And we want that waist. We don't want to take that skin. It used to be abdomen. Let's make it abdomen again.
Yeah. And a lot of patients, I think, don't see that as well, is that you want to maintain that volume and really manipulate the contour and the shape and positioning rather than cut it out and try to form something new. It remains more natural. So what's this?
So this is basically the plan. This is now a bottoming out. So this is a longer case. Maybe the implant wasn't so low. Maybe it was a bit higher. But just on my Instagram, it just highlights how I think about things. So how do I know, you know, the breast should be there? Well, look, you know, I want to have some sort of a measure from the sternal point here down to the xiphisternum here, and I want some sort of unity between that length and from that length down to the iliac crest, which is the waistline. So we want as much breast as waist at least, or if anything, more waist than breast, because that keeps you looking thin. And we don't want to lose the breasts give you the out part of the hourglass, but we don't want to lose the in part of the hourglass. As we come down, we lose the in part of the hourglass. So if we're starting to crowd over the in part of that hourglass, that breast needs to sit higher. But I'm not cutting that skin out. We're just going to lay it back down and make it abdomen again. We're going to make it waist again with all the internal support we can do. And so when these canes come, they don't need a lift. They just need all that waist restored.
So here you're forming more internal bra support, internal pexies.
Correct. Yeah, correct. Exactly. And that will give you more cleavage in turn. So Dr. Subio, who many of you I'm sure follow because he's so funny and is our daily laugh, he sent me this, and it's a really good way, and it kind of looks like me too. So I've used it in a few talks, but basically I was trying to communicate to say why this internal support is not just important for the waist, but also to your cleavage. And the reason is the breast is never designed to have implants. You know, it was just sitting there. It doesn't have nearly enough support. It's got no floor, if you like. So we have to, as surgeons, put a big floor here. So then whatever you do can then push volume that way or upwards or whatever you want. If there's no floor, you've lost the game, because everything's going to A, bottom out, and B, even if it doesn't bottom out, seem too low. So cleavage is very heavily dependent on that hammock. So we've got to build that floor, and then I can push towards the cleavage. Without that floor, you can't do it. You need a floor.
Yeah. And you're playing against gravity and all this.
Again, so that lady in the first shot has no floor, or a floor that has disintegrated. And guess what? Her cleavage lines are far apart, right? You can't wear those dresses. But we're going to restore the waist, create a floor, and with these types of cases that are that low or they're bottomed out that much, I would do 2 full layers of barbed stitches, often permanent, and that skin is laid back down. They've got a strong floor, and then you get your cleavage. You get your cleavage back to and then do the gradient and all that, because the action's back to where we want it.
And with these, I would assume, just like with breast implant surgery, that at some point in the future you might need to touch up or lift it again.
Yeah, so basically with all implant surgery, and people who are new to all of this and they haven't really researched implant surgery, assume every 10 to 15 years, I say in my practice, we need to update your implant. It's like cars. Like you can buy a brand new car now, but it is, if you have an implant, it is a foreign object. Technology is going to get better. We're going to get better implants. And I purposely haven't talked about any brands, and all the implant companies are good. People have their preferences and so forth. But the point is, 10 years later, we're going to have better ones. We just are. And and plus the integrity of the implants, they can break and so forth from all the things they put. So assume every 10 to 15 years, even if they look perfect, just change them to a new model, service the car.
That's something that I haven't really heard in the argument of changing implants or not. Most people just focus on, well, it hasn't had a problem yet, it's probably not going to have a problem. But I do think that there's a lot to say for that, where yes, the implant quality itself has changed over time. They've got more integrity, they've got different substances within them.
Correct.
So I think there is something to be said just for that, for updating into something that is better quality.
Yeah, and just the timing of it, in the woman's life cycle, they had the implant early, and then they may have had a family and so forth, and so naturally things have changed.
And they will have aged over that time.
Be aged, and even for, just as you said, getting the glow back in the skin, or just starting to make things look more aesthetic and youthful, or getting the torso back or the waist back, all these sort of things.
So you see them back to do little touch-ups, and I'm sure there's cases
always with a new implant, because you might as well get the latest one. Yeah.
Right. If you're doing that, and so this is the.
I just sort of ended on that one because I thought it was a great shot, and artistic with the black. I was last night just screenshotting these, and I just caught my eye. But look, it's just basically the recurring theme here, and I guess what you take away from it today is that cleavage is a really big part of what I do, and where breast aesthetics is going, and it's not because of me and so forth, it's because of just what we're seeing from people sending selfies and from what people are wearing. As I say, just look at any next red carpet event or any formal dress, and I don't need to tell the ladies, because they know all this, how many strapless dresses, plunging necklines, backless dresses, very loose bikini, bralettes never existed. Bralettes are basically, do you know what a bralette is? A bralette is basically a very thin wisp of cotton, lacy, with absolutely no support. It's exactly the same as not wearing anything, really. So these things are around us, and so us as breast aesthetic surgeons need to factor that into our decision tree.
Yeah.
And we only know that because we're getting all these amazing selfies. And so that's why, straight away, I when I meet a breast specialist, I know their
I got to
Instagram
cut you off actually,
profile.
because we're about to get cut off by Instagram.
Oh crap! Whoops. Okay.
No, it's all right. I just want everybody to know how to find you, and that you're making these amazing changes without being cheap with volume, and you're really worrying about how people look in public all the time, and it's amazing. So
thanks so much for having me.
Yeah, so Dr. Michael Miroshnik, he's in Sydney, Australia. You can find him on Instagram. He's the breast cleavage master on Instagram. Dr. Miroshnik.
Yeah. Thanks. Yeah, very much for having me. I haven't done one of these, but it's been fun. Thank you very much for your platform.
Yeah, so we'll have the podcast up soon for everybody. They can watch us on YouTube, and if you go to his Instagram page, you will be impressed on how sexy these photos are that he gets, and that's really what you want. It's breast surgery. So we're getting cut off. Thank you so much.
All right, over and out. It's been fun. We'll see you later.